Welcome to the Breath Beat podcast. In this episode, we are going to talk about the obstructive sleep apnea, central sleep apnea, and obesity hypoventilation syndrome.
Imagine waking up tired day after day, maybe despite sleeping for 8 hours. You might blame stress, maybe your diet, or I don't know, even your mattress. But what if the culprit is something you're doing every single night without even realizing it? Today in the deep dive, we're pulling back the covers on, a kind of hidden health crisis, sleep-related breathing disorders. We're taking a deep dive into conditions like obstructive sleep apnea, central sleep apnea, and various sleep hyperventilation syndromes. We're pulling insights from the latest clinical guidelines. Our mission today is to give you a shortcut to being truly well-informed about these conditions, how they're identified, what they mean, and crucially, the whole array of ways they can be managed. We'll extract the most important nuggets of knowledge and maybe some surprising facts too to help you understand this vital area of health. Okay, let's dig in.
Yeah, it's fascinating really how these sleep-related breathing disorders often get lumped together. People just say sleep apnea, but they're actually quite distinct conditions. The primary distinction we probably need to make right off the bat is between obstructive sleep apnea, OSA, and central sleep apnea, or CSA.
Okay, obstructive versus central.
Exactly. So think of obstructive sleep apnea, OSA, as more of a plumbing problem. It's characterized by these recurrent episodes where the upper airway, so the passage your air travels through, it actually collapses during sleep.
So even if you're trying to breathe.
Right. Your body's making the effort, but the air just can't get through easily. Kind of like trying to drink through a bent straw. You'll often see symptoms like loud, consistent snoring, maybe a partner witnessing breathing pauses or gasping, and of course feeling excessively sleepy during the day no matter how much you felt like you slept. Just unrefreshing sleep.
Okay, that's OSA, the blockage. What about CSA?
Now, central sleep apnea, CSA, is totally different. This isn't a physical blockage. It's more like an electrical problem, you could say. Your airway might be perfectly clear, but for a moment, your brain temporarily fails to send the right signal down to the muscles that control breathing.
So the command center just glitches for a second?
Sort of, yeah. It's like the circuit breaker momentarily trips and your body just forgets to take a breath. There's no effort.
Wow, okay. And you mentioned hypoventilation too.
Right. And then we have these sleep-related hypoventilation disorders. Now, these are distinct from CSA mainly because they directly impact your carbon dioxide levels. With hypoventilation, your body isn't effectively getting rid of enough carbon dioxide, so you end up with abnormally high levels in your blood. We call that hypercapnia.
Okay.
With central sleep apnea, though, CO2 levels are typically normal or sometimes even a little low. Yeah. So hypoventilation is really about too much CO2 building up, whereas CSA is more about the brain's signal for breathing itself being absent sometimes.
That distinction really helps clarify things. And what often catches people off guard, I think, is that sleep apnea isn't just a nuisance. It's not just about being groggy. The ramifications, they extend far beyond just feeling tired, right?
Absolutely. Untreated sleep apnea, especially OSA, isn't just linked to serious health issues like high blood pressure, heart attack, stroke. It actively drives them.
Wow.
Yeah, it's becoming recognized as one of the most significant unaddressed risk factors in cardiovascular health, sometimes even more impactful than some traditional culprits people think about.
That's truly startling. It really shows how interconnected everything is. So given those serious potential long-term risks, it really highlights why getting a diagnosis isn't just about better sleep. It's about, safeguarding your overall health. How do doctors even begin to unravel this, beyond just spotting the obvious signs like snoring? It sounds complex.
That's the crucial next step, yeah. The diagnostic process, usually for OSA, involves a really comprehensive sleep evaluation. It typically starts with a detailed conversation, about your sleep habits, your history, and then a physical examination.
Okay.
We'll ask about that snoring, sure, but also daytime energy levels. Do you wake up feeling refreshed? Has anyone ever seen you stop breathing or gasp while you're asleep?
Right. The partner perspective can be key.
Definitely. We might also use simple questionnaires like the Epworth Sleepiness Scale, just to get a clearer, more objective picture of how sleepy you are during the day. And the physical exam looks for things like obesity, any signs of a narrow airway, even neck circumference can be an indicator.
Neck circumference.
Really?
Yeah, it sounds surprising, but over 17 inches for men, over 15 for women, that's often associated with higher risk. But the definitive step, the gold standard for most of these sleep-related breathing disorders, is an objective sleep study. Usually that's polysomnography or PSG.
The overnight study in a lab? Exactly. That's the one. We monitor a whole host of things: brain waves, eye movements, muscle activity, heart rate, how much air is actually flowing through your nose and mouth, your oxygen levels, your breathing effort, body position, all while you're asleep.
It sounds like a lot of wires.
It can be, yeah, but it gives us incredibly detailed information. The PSG helps us calculate key metrics. Probably the most important one is the Apnea-Hypopnea Index, or AHI.
AHI.
That basically counts how many times per hour of sleep your breathing either completely stops, that's an apnea, or significantly drops, hypopnea. That AHI number tells us the severity: mild, moderate, or severe OSA.
And are there other ways besides the full lab study?
Yes, there are. For certain patients, usually those who have a pretty high likelihood of moderate to severe OSA and don't have other major health issues going on, we can use portable monitors.
Home sleep tests.
Right. Home sleep apnea tests. There are simpler devices you can use at home in your own bed, but they aren't recommended for everyone. If someone has significant heart or lung disease, or if we suspect other sleep disorders, the home test might not be accurate enough. It could underestimate the severity.
Got it. So the takeaway here seems clear. If you have those persistent symptoms, that chronic tiredness, the snoring, maybe your partner is nudging you all night, getting a proper diagnostic evaluation is absolutely critical.
Couldn't agree more.
Knowing the specific type and the severity, that's really the first step towards getting the right treatment and, preventing those serious long-term complications we talked about.
Okay, so someone gets that diagnosis, OSA, maybe CSA. What comes next? It really sounds like there's no single magic bullet, especially with all these different types.
No, definitely not.
How do you tailor treatment when there's so much variety?
You've hit on the core principle, really. We have to approach sleep-related breathing disorders as chronic conditions.
Right, not a quick fix. Exactly. They demand long-term, personalized management. And often, it involves a multidisciplinary team, speech specialists, maybe dentists, surgeons, primary care docs.
Makes sense.
So for obstructive sleep apnea, OSA, the most common, and frankly often the most effective treatment, is continuous positive airway pressure, CPAP.
The CPAP machine, yeah.
Right. It's a device that delivers this gentle, continuous stream of air pressure through a mask you wear at night. It basically acts like a pneumatic splint, an air splint, just to keep your upper airway open so it physically can't collapse while you sleep.
Right, it works well.
For moderate to severe OSA, it's highly effective. It can dramatically improve daytime sleepiness, quality of life, but getting the right mask fit and consistent follow-up are really, really key for people to stick with it long-term. Adherence can be a challenge.
Right, I can imagine. And for those who do struggle with CPAP, maybe it's uncomfortable or just hard to get used to, are there alternatives?
Absolutely.
Yeah.
Yeah, not everyone tolerates CPAP perfectly, and that's okay. For many, especially those with maybe mild to moderate OSA, oral appliances, OAs, are a fantastic option.
Like mouth guard.
Pretty much, yeah. They look similar. They're custom-fitted devices you wear during sleep. They work by gently repositioning your jaw or your tongue forward, just enough to prevent the airway from collapsing from behind.
Interesting.
It's crucial, though, to have a qualified dental professional involved, both for the initial fitting and for ongoing monitoring to make sure it's working and not causing any dental issues.
Okay. So CPAP, oral appliances. What else?
Well, beyond devices, behavioral treatments are incredibly important for both OSA and some types of hypoventilation. For patients who are carrying extra weight, weight loss can make a really significant difference. Well, excess weight, especially around the neck, can physically narrow the airway. So losing weight literally helps open it up. The dose rate from diet alone isn't super high, but it can definitely improve things and make other treatments like CPAP much more effective.
Makes sense.
Also, simply changing your sleep position. Some people only have apnea when they sleep on their back.
Positional apnea.
Exactly. So avoiding sleeping on your back can be effective. There are even simple devices like special pillows or belts that can help you stay on your side or stomach. And of course, avoiding things like alcohol and sedatives, especially close to bedtime, is always advised. They relax the airway muscles even more, which can worsen apnea.
Right. Don't make the problem worse.
Precisely. Then when other treatments aren't enough, or if the anatomy, the physical structure is really the main issue, surgical treatments can be considered for OSA.
What kinds of surgery?
Oh, there's a range. It could be procedures to reduce tissue in the throat, like removing tonsils or reshaping the soft palate. That's called UPPP. Or more involved surgeries to actually advance the jawbones forward, like maxillomandibular advancement. In really rare severe cases, a tracheostomy creating an opening directly into the windpipe might be necessary, but that's usually a last resort. The specific surgery really depends entirely on what is causing the obstruction in that individual.
Okay, so quite a few options for OSA, the obstructive kind. But what about central sleep apnea, where the brain isn't sending the signal? How do we tackle those electrical issues, especially when they might stem from different underlying causes?
Yeah, that's where the approaches really diverge quite a bit. For central sleep apnea syndromes, CSS, and sleep hypoventilation, the absolute key is to identify and, where possible, address the root cause.
Right.
For primary central sleep apnea, that's CSA, without an obvious underlying medical cause sometimes, certain medications can be trialed. Things like acetazolamide or even some sleep aids like zolpidem or triazolam might help stimulate breathing or reduce those central events. But we have to proceed with caution because of potential side effects and drug interactions. Data supporting this is somewhat limited.
Got it. What if it's linked to something else like heart failure?
Right. So if the CSA is due to that Cheyne-Stokes breathing pattern you often see in people with congestive heart failure, the very first step is always to optimize the heart failure treatment itself. Get that as good as possible.
Makes sense. Treat the underlying condition first.
Exactly. Then specialized devices called adaptive servoventilation, or ASV, are often recommended.
ASV, how's that different from CPAP?
ASV devices are incredibly smart, really. They continuously monitor your breathing pattern moment by moment. And they automatically adjust the pressure support they give you to specifically counteract those pauses and stabilize your breathing rhythm.
Wow, very sophisticated.
Yeah. Supplemental oxygen can also be helpful in that situation. And if those aren't enough, we might consider specific medications like acetazolamide or theophylline.
Okay. What about other causes, like high altitude?
For CSA, due to high altitude periodic breathing, well, the most straightforward solution is pretty simple. Descend from altitude or use supplemental oxygen.
Right. Get more oxygen.
Yeah. If that's not feasible, the medication acetazolamide can be used both for treatment and sometimes prevention before ascent. And just ascending slowly can help prevent it in the first place.
And what if it's medication related? You mentioned opioids earlier.
Yes. When central sleep apnea is due to drug or substance use, particularly opioids, the ideal scenario, if it's safe and feasible, is to reduce or discontinue the substance.
But that's not always possible.
No, often it's not. In that case, a trial of CPAP is usually the first line. If CPAP isn't effective, then ASV might be tried. Now, if we see high carbon dioxide levels developing in that situation, the hypercapnia we talked about, then a different type of positive airway pressure is usually advised. It's called bi-level positive airway pressure in a spontaneous timed mode, or BPAPST.
BPST. Okay.
And speaking of high CO2, that brings us to obesity hypoventilation syndrome, or OHS.
Right, where the body isn't breathing effectively enough because of obesity.
Exactly. Often an initial CPAP trial is common here too, but if oxygen levels remain low or those CO2 levels stay high despite CPAP, then we usually move to more advanced support. That could be bi-level PAPI or BPS, which gives different pressures for inhaling and exhaling, or BPST, that timed mode, or even something called average volume assured pressure support, AVAPS, which adjusts pressure to guarantee a certain volume of air with each breath, ensuring adequate ventilation.
So more powerful ventilation support.
Essentially, yes. Again, for severe persistent OHS, a tracheostomy might be considered. But it's important to note that significant weight loss, perhaps through bariatric surgery, can often be curative for OHS.
And you mentioned neuromuscular conditions.
Right. Finally, for sleep breathing issues stemming from neuromuscular or chest wall disease conditions that affect the muscles or structure involved in breathing positive airway pressure, often BPST or AVAPS, it's typically introduced relatively early to support breathing function. And really close follow-up is critical here, as these conditions are often progressive.
Okay, one quick clarification. What about just using oxygen?
Good question. While supplemental oxygen can help with low oxygen levels, it needs to be used very cautiously in hypoventilation syndromes, like OHS or neuromuscular disease.
Why is that?
Because if you just give oxygen without also supporting the ventilation, the removal of CO2, you can actually blunt the body's natural drive to breathe, which can make the carbon dioxide retention even worse. So it often needs to be coupled with something like BiPAP.
Got it. So oxygen alone isn't always the answer. Might even be risky sometimes.
In those specific hypoventilation cases, yes.
Wow, that's That's a really comprehensive overview of the treatment landscape. It truly underscores how personalized this care needs to be. So once a treatment plan is in place, CPAP, oral appliance, whatever it is that it? Or is this more of an ongoing journey?
Oh, it's absolutely an ongoing journey. We have to remember these are chronic conditions. So long-term multidisciplinary management is essential. Regular ongoing follow-up is just critical for several reasons, really.
Like what?
Well, first, to ensure you're actually using your therapy consistently. Adherence, remember.
Right.
Second, to identify and address any side effects or problems. Maybe the mask isn't fitting right or it's causing dryness. Third, to check for any complications related to the disorder or the treatment. And fourth, just to confirm that your symptoms, the sleepiness, the snoring, whatever it was, remain resolved.
So it's about fine-tuning and maintenance.
Exactly. For example, if you're using CPAP or BiPAP, those follow-up appointments are crucial to ensure the mask is still comfortable, you don't have air leaks, maybe you adjust humidity settings, and importantly, confirm that the pressure settings are still optimal for you. Your needs might change over time.
And for the oral appliances.
Same idea. Regular checkups with the dental professional are vital. They monitor the appliance's fit, its effectiveness, make sure it's not causing any unwanted changes to your teeth or jaw.
What about after surgery?
Even for those who've undergone surgery, post-operative follow-up is absolutely critical to assess the outcome. It's really important to remember that surgery doesn't always provide a complete cure. Sometimes there's residual sleep apnea that still needs to be managed, maybe with CPAP or another approach.
So reassessment might be needed.
Definitely. If symptoms come back, maybe after an initially good response, or if significant changes happen in your life, like noticeable weight gain or loss, another objective sleep study, maybe a PSG or home test, might be needed to reevaluate things and adjust the therapy accordingly.
And patient education must be huge throughout this.
Paramount, absolutely. Patients need to be counseled on the nature of their specific disorder, all the available treatment options, the pros and cons of each, and strategies for self-management, providing resources, websites, handouts. It really empowers patients to take an active role in their own care.
What's truly striking about managing these conditions is just how dynamic it is. It really demands continuous attention and close collaboration between the patient and their healthcare team.
Yeah.
It's such a testament to the fact that health is rarely a one-and-done kind of fix. It's really an evolving partnership. So today, we've taken quite a deep dive into this intricate world of sleep-related breathing disorders. We've gone from the subtle but important distinctions between OSA and CSA, all the way through the wide spectrum of diagnostic tools and the many treatment options available. It's clear these are complex conditions, definitely not simple, but they are absolutely manageable.
Yeah, I think if we zoom out a bit, connect this to the bigger picture, the key takeaway really is the profound importance of getting an accurate diagnosis first, and then having a truly personalized, multidisciplinary approach to care. Whether it's CPAP, oral appliances, behavioral changes like weight loss or position therapy, or maybe more advanced medical devices, or even surgical options, effective strategies exist. And they can significantly improve not just sleep, but overall health outcomes and quality of life.
So what's the ultimate implication for you, the listener? This deep dive, I think, reminds us that what happens when we close our eyes is far more intricate and, frankly, far more impactful on our health than we often imagine. Understanding it isn't just about getting a better night's rest, though that's important too. It's really about potentially unlocking a pathway to genuinely healthier, more energized living. So next time you, or maybe someone you know, struggles with that persistent daytime sleepiness or loud snoring or just feeling unrested, remember, it might be more than just tiredness. It could be a signal from your body to look a little deeper.
Thanks for tuning in to The Breath Beat, where every breath counts. We're grateful to have you with us as we explore the latest in respiratory care and sleep science. If you found this episode helpful, please subscribe, like, leave a comment, and share it with your colleagues or friends. Your support helps us keep the conversation going and reach more listeners in the respiratory community. Stay tuned. We've got more insightful episodes coming your way soon. Until then, take care, keep breathing easy, and we'll catch you on the next beat.